All right, why don't you go ahead and I'll figure it out.
Okay.
I'll email him.
All right, just to make sure. Okay, so.
Otherwise, you'll just email me your slides. We'll make them available.
Yeah.
Okay.
Yeah, I mean, it's always nice to have the voice too, but.
Yeah.
All right. Okay, well, welcome. I'm Kirsten Tillish. I am an associate professor of gastroenterology here at UCLA and the chief of integrative medicine at the Greater Los Angeles VA. And I'm going to talk to you today about integrative and mind-body interventions for chronic pain. So, as an overview, I'm going to go over briefly what are the integrative and mind-body interventions, what do we mean by that, what are some of the research challenges in integrative and mind-body interventions. We deal in this area with the tyranny of the double-blinded, placebo-controlled trial, which can be a frustration for many of us doing this research in mind-body interventions, where that type of trial is really quite difficult or impossible. I'm also going to talk about research opportunities in integrative and mind-body interventions. For those of you who may be thinking of a career in this area, is this a great niche for you to develop a career in research, or is this a career killer, as I was told when I was starting my career in this area a decade ago? And I'm not entirely sure at this point, but I'll talk about that a little bit. And then I'm going to just talk for the bulk of the time on irritable bowel syndrome, which is the area that I study, and it's a really good model of chronic visceral pain syndrome. And also, it turns out, while it's a visceral pain syndrome, there are a lot of overlaps in the outcomes in mind-body interventions for visceral and somatic pain. So I'm going to use this as a model for discussion, particularly talking about brain changes as a biological outcome of mind-body interventions, and mind-body interventions for symptom relief. So what do I mean by integrative and mind-body? Well, integrative medicine interventions, if we use the NIH definitions, combine mainstream medical therapies with complementary and alternative medicine therapies for which there's some high-quality scientific evidence for safety and effectiveness. And what they really mean by this is these are things that have been shown to be useful that we don't necessarily use instead of our standard approaches to medicine, but we integrate them with our standard approaches. And they can be used as standalone as well. Examples of this would be acupuncture, massage, herbal medicine, probiotics, meditation, hypnosis. When I talk about mind-body interventions, what I mean are interventions which target the mind as the focus to make change, but may improve body symptoms or vice versa. So a classic mind-body intervention would be something like cognitive behavioral therapy, meditation, or hypnosis to target pain symptoms. We're not doing anything for the location of the body where the pain is felt, but where the pain is processed, that's where we're targeting our intervention. To go the opposite direction, something like exercise, where we're actually doing a body intervention, we actually can see improvements in things like mood and cognition. So mind-body interventions can go both directions. And I think it's really our interest in mind-body interventions, it comes from the recollection that the mind and body are in fact attached and are one thing. So if we're looking at ourselves and others as holistically as possible, a mind-body intervention makes a great deal of sense. So why focus on mind-body techniques? Why did I choose this as my area to look at? Well, our current model of disease or treatment is disease-oriented rather than person-oriented and very specialty-oriented. I'm a gastroenterologist. My role is really to treat the gut and not necessarily to pay attention to the rest of the body, though of course I should. We have a sort of find and fix approach. What's wrong? How can I fix it? And we react to symptoms rather than try to prevent symptoms. And this model, which really has moved medicine forward very successfully in some areas, fails in quite a few areas. One of them, most dramatically, being chronic pain, and I think also in the area of mood disorders. We have an incredibly expensive healthcare system. Despite being the most expensive healthcare system in the world, we have a lifespan that's going down. We have rising obesity and metabolic syndrome. We have people who are getting more sick and not more well. And so clearly there's something wrong with the traditional approaches that we've been taking in Western medicine. We also know that patients are seeking other options to care, and they really gravitate many to integrative and mind-body techniques. So it's something that's important for us to take seriously. These issues are really amplified in some populations, and certainly in the population I see at the VA, this is the case. There's a great deal of comorbid psychiatric disease across the country, and particularly concentrated in the VA system. There are many barriers to compliance and wellness that may make it more difficult for patients to, for example, take antidepressants or take pain medications safely. And there's an interaction between stress and negotiating well in the healthcare system, where there are issues of trust, where the traditional hospital-based system has not been kind to some patients and has made them feel unwelcome. Taking a mind-body approach or an integrative approach can sometimes bring people back to working with physicians and other clinicians in their healthcare. So in terms of use in America, this is a somewhat old statistic, but at least a third of people use CAM and probably more. They most commonly use natural products and supplements. But they also use other modalities, including meditation. Down is smack dab in the middle, in the 6% range, was yoga. There have been a number of articles recently showing that yoga is really growing in this country as a complementary intervention for health, not just for exercise, which many people have thought of it as. And when we look at conditions that people use CAM for, chronic pain is really the top of it. When we look in the VA population and active military as well, they really use alternative modalities and integrative modalities more than the general population. And this is actually in part because the active military, the Department of Defense, has started to implement a number of integrative approaches in the training and care of active military, because the need is so great. And so acupuncture, yoga, meditation, these are things that are starting to be implemented in active duty situations, and the VA is a little bit behind, but also coming on board with that. About 27% report using these specific modalities of acupuncture, biofeedback, or energy healing. Oops. Those military personnel who have PTSD, which is very difficult to treat and very aversive for many of them to treat in conventional ways, they're more likely to seek out integrative or alternative methods. And when queried whether they would use integrative or alternative modalities at their local VA, 76% of those with chronic pain said that they would. And unfortunately, many of them don't have access at their VA. So what are types of mind-body therapies for pain? In general, they are things that focus on relaxation, focus on calming the nervous system. They may include meditation, biofeedback, hypnosis, yoga, guided imagery. And when we think about these types of therapies, when we're designing research, we have to think about the ideas of, do they work via a very specific mechanism or general mechanism? So do all of these things do the same? If I send a patient to do biofeedback or I send them to learn meditation, am I sending them to the same thing or something quite different? It's important for me to know that. Do they affect the body as well as just the mind? So some people would argue that these types of interventions may make people less likely to report negative symptoms of pain, but may not actually change the pain itself. And it's a really difficult thing to tease out. Are they different than a placebo? Well, what is a placebo? A placebo is basically an intervention that has non-specific effects. So if meditation has non-specific effects, is that the same as a placebo? Is answering these questions really important? And I think that is a really key question. I think it is important in the area of research for our patients. They just want to know that one of these things will work and they have access to them. Most people don't really care if the effect is very targeted and specific or more generalized and non-specific, as long as they feel better. So we deal with this gold standard in clinical research, and for those people listening who are planning to do research or interested in research, it's a real conundrum for those of you who might pursue studies in any of the integrative or mind-body techniques. When you write a grant or when you submit a paper for publication, we deal with this ingrained belief that all studies must be, to be high quality, double-blind, placebo-controlled, and randomized in the model that we have for medications, where we know what we put in the pill, we know what we put in the placebo. Often, though not always, we can even check blood levels to know how much is getting into the patient. And we think we know exactly what's going on. I would argue that we really don't, in most cases, know exactly what's going on. In many of these studies, there are subtle placebo or non-specific effects that occur. But this is a strong bias in the research community that when you're dealing with something that you can't easily double-blind or placebo control, you'll have to deal with. And it's best to deal with head-on. So one of the challenges is for your intervention. When you have a mind-body intervention, is it something that's standardized? Is it something that you can do reliably every time you do it? The person is getting the same thing? Or is it something that really does not lend itself well to being standardized? The more standardized it is, the easier it is to get it funded and published, but that may not be the best way to treat your patient. So that's one of the challenges we face. Is there a specific training, certification needed to do this intervention? We sort of know who is allowed to do surgery and who's allowed to do medical interventions, but it's harder to know what's the training required, for example, to teach mindfulness. Is that something where you need a MBSR, mindfulness-based stress reduction, certified practitioner? Is that something where you need a very interested professional clinician who has some training? Is it something where you can have a person, that you hire as a research assistant learn in a course and then deliver? And is there a significant difference in the response of the patients based on who gives that intervention? So it's quite important to know where the intervention comes from. And what's interesting is we always think like, oh, well, the more they, 20 years of experience, and they do silent meditation retreats 3 times a year, and we assume that person is going to be the better teacher than someone who took a short course. But there's really no data to support it. So our assumptions may be correct or they may not be. And so that's something that is a research challenge we deal with, and I think an interesting practical question. How do we measure the fidelity of the interventions? If we say we're doing meditation, how are we making sure that the people delivering the instruction are delivering it correctly, and that the person that's being trained, the patient, is doing the thing that we think they're doing? And what's the dose or the best duration of therapy? For most of the mind-body interventions, we have some data that they're useful in individual studies. But for example, in the Tai Chi literature, there's plenty of information that Tai Chi may be helpful for specific things, but there's very little specificity about which specific movements should be used, how long should they be used, what combination. The same with yoga. We don't know things like dose or duration very well. What control group are we going to choose? Can we compare to a wait list? Most people kind of look down on that. There are a lot of reasons why a wait list may bias people in a negative way. You feel like you're on a waiting list. You kind of kicked to the curb, and so you may feel worse because you feel ignored and you're waiting rather than getting an intervention. But then again, how do you design your intervention? There are a number of very well-done studies from good groups looking at an active control intervention by comparing meditation or comparing specifically designed CBT intervention, where the education control groups are really very good, and they're often delivered by people who have a fair amount of education in the areas that the competing intervention is being done. And so you may have some bleeding over in your education group. It's really difficult to take a well-meaning clinician and have them give a really dry education group. And we've certainly had that experience here and with some collaborators where the person giving the education group just knows too much and is too kind, and they just do a really great job. So maybe education by a really nice clinician is just as good as some of our other interventions. I'll show you some data, I think, later that shows that they may act a little bit differently. So what's our comparison group? In most mind-body things, it's very hard to do placebo. So there have been sham or placebo meditation studies where they have people sit and do nothing, or give them instructions that are unhelpful, and then they give another group helpful instructions. But for most of us, sitting quietly in a room for 20 minutes is probably a beneficial thing if we can relax while doing it. So that still is an active intervention. So this is another tricky area. How specific are the effects of the intervention is a question that isn't one that intrigues me a lot, but it really intrigues program officers at the NIH and reviewers in journals. So when we do an intervention that is a mind-body intervention, and I say that mindfulness-based stress reduction helps irritable bowel syndrome, people say, well, what is it? Is it being mindful that affects it? Is it just because they feel better and they go out and they change their diet? Is it because they start doing some yoga and then they start doing more yoga and they're doing more exercise? What is the secret sauce in there that helps the patient? And in some ways that's important to know, because we would like to be able to simplify and optimize our interventions so that they work best for our patients. But on the other hand, we just need to find some things that work and in some ways take these complex interventions at face value sometimes. Will these interventions work differently in different populations? Do we expect them to help us like a pill does just while you're using it, or will there be long-term benefits once you stop? How do you measure that? What's the best way to measure that? These are important things to consider in your research. And what outcome measures will you have? In pain, we're often dealing with subjective measures, which are frustration for many people because they certainly can be biased. People can want to please the investigators they're working with. Or sometimes they can be biased negatively if there's an experience that's negative. But really, that's what we have. The patient-reported outcome is what we have to work with. We can be careful when we pick those measures, and we can also make sure we pick measures that don't reflect just, say, intensity of pain, but also disability associated with pain or interference of pain with lifestyle when we're picking those measures. So it's important to pick a broad enough collection of validated measures so that you're measuring not just one aspect of pain, but a more holistic view of that pain construct. Often people use experimental tasks. So for pain, acute pain stimuli are often used, and there's some ways in which that might be helpful. But for the most part, the experimental tasks don't track all that well with the pain that people live with as the clinical symptom that causes them trouble. And then biological measures. Are there other outcomes that we can look at in terms of inflammation, autonomic nervous system function, brain structure and function? And we'll talk about that. So that's the difficulty and the quagmire that you can fall into when you're looking at mind-body interventions. But there are lots of opportunities as well, and so I think it's an area that's fascinating and interesting to work in. So we do have the NCCIH, the National Center for Complementary and Integrative Health. They have a budget that has been flat for the last decade at around 120, 125 million. It's gone up and down around there. But a little bit of a bump, I guess, this year as the NIH funding has finally increased a small amount. It's a tiny piece of the NIH pie, but it's a piece that is dedicated to this type of work, and mind-body interventions are one of the focus areas of their research. So that's a source of.
But there's also other, the heart and lung also funded, studies as well. NCI also funded studies. So
increasingly, and you can actually look when you look at the list. There is almost all of the institutes fund some sort of complementary and integrative health. It's even smaller piece of their individual budgets, but it's certainly in there. And often they co-fund, or NCCIH may find something they're interested in funded and may partner with another institute. So that is an underrepresentation of what could be funded.
Because we did the biofeedback relaxation technique for hypertension study with R01 NIH for 3 years. So there was I can't remember now, 2007 or even earlier than that. So this is another area that I think would people can get funding from, not just.
I think it's increasing, but I think it's certainly a tough.
It's minuscule.
Yeah, it's minuscule, exactly.
Homeopathic.
It's homeopathic, and some institutes like NIMH says absolutely not, will not fund anything that says meditation.
Right. NIDA is an institute that's more open.
How about NIA?
They would fund it. They're increasingly interested in lifestyle where yoga belongs, or Tai Chi belongs. They listen, and they just funded a single grant only in collaboration with private foundation that has mindfulness compared to aerobic exercise for cognitive health. So, and they funded maybe historically over the years, for the last decade, exercise studies for aging.
I think it's an area where it will increase as people become a little bit more open. When I look, so my study area, irritable bowel syndrome, if you just query how many grants are funded at this current time in irritable bowel syndrome, there are 94. Now, this is a disorder that affects almost 10% of our population, so it's not a negligible disorder. But if you look at how many are funded in meditation, 106. So one could argue that I have just as good of a chance getting funded in meditation as I might in irritable bowel syndrome. Fewer studies in yoga and fewer studies in acupuncture if you look at what's actively funded now, though that's just a broad view, and if you delve into that, there certainly are a lot of fine gradations in how things are funded. But just to make the point that these are areas that do get funded by the NIH, despite the fact that it's still difficult. There is philanthropic support, and what is wonderful for us in the area that I work in is patient interest is very high. So while there are many hurdles to get funded, and there are many hurdles to design the studies carefully so that we get good information, it's much easier to recruit patients for a study of meditation or a study of probiotics than it is for a investigational drug or a study in which we inflict experimental pain on people. So it is there are definitely some pluses in doing this kind of research. So mind-body research is cool, but why focus on the chronic pain aspect of it? I think I sort of alluded to why I think that's so important. Chronic pain is an area where we really need to shift the way we treat our patients, and research needs to shift as well. Pain is a huge problem, and I have no idea when I made this slide quite a long time ago why I put a pink elephant with sunglasses on it, but I did, and when I brought up this slide just recently,
There must be something wrong with million. You're talking about billion, not million.
Of annual cost.
It cannot be million. I mean,
I think actually it was million at the time that I made this. So
no,
most
I
of
think
us
that
will have
the pain people would not. You're talking about a
the
lot of
cost,
people.
yeah.
You're talking about not direct costs. You're talking about loss of productivity and stuff like that.
So if you look at annual costs of medication and medical care, but certainly if you include all costs, so yeah, you'd have to look into that more specifically. But really, the point of this slide is that most of us will have some sort of pain or chronic pain in our lives. Our workforce, over 50%, has some type of pain, most likely back pain and headache, but also joint pain, neuropathic pain, and irritable bowel or other visceral pain. Of the estimated 100 million Americans currently suffering with chronic pain, about half of them feel that they have inadequate relief with the treatments they have available to them. And those are people who are being treated. When we think about what pain is, it helps us understand why the treatment is so ineffective. The International Association for the Study of Pain calls it an unpleasant sensory or emotional experience associated with actual or potential tissue damage. So pain is something that may be causing damage, but doesn't necessarily cause damage. Chronic pain may be the result of an insult to the body that is long gone, but the memory and scar of that pain still resides in the brain, and so the pain is still sensed with the same intensity that it was before. This is a very difficult concept for some people to wrap their heads around, and patients often get offended when you try to explain this to them if you're not careful. And even if you are careful, they often jump to you thinking that they have a psychological problem, and that that's in some way punitive. The pain is real, but where it's coming from isn't always where we think. So for this disorder, which is the most common reason people go to the doctor because they're in pain, we have a site, for example, the hand, where a nidus of pain may occur. There's transduction of that pain to the nervous system, transmission of it through the nervous system to the brain, perception of that pain in the brain, and then modulation by the brain. And most of the research that has been done has focused on that bottom part of the system. When we're in pain, the body responds with a complete systemic response, with changes in muscle tension, heart rate, blood pressure, breathing, attention, emotional changes. So the dot where the pain is may be the start of it, but it becomes a systemic problem. So our traditional research and therapy of pain has focused on the periphery, on transduction of pain, on the concept of nociception, rather than pain as a affective process, and on the transmission of pain in the nerves. Often it's forgotten the affective component, the cognitive component, the motivational and memory component. So we've sort of cut off the head when we've studied pain for the most part, which was led to really a failure of our animal-based research, where we found all these wonderful pain medicines for animals that have been pain has been inflicted upon, but not drugs that have helped humans. We're still dealing with the opiates, the non-steroidal anti-inflammatories, antidepressants, seizure medications, and newer and modified versions of those, which have not advanced in the last 20 years in the way we'd like. So moving to irritable bowel syndrome as a model disorder for mind-body interventions. Irritable bowel is a common disorder, so at least 7% of Americans have IBS, maybe higher. Women are 1.5 times as likely to have IBS as men. Most people think that it's higher than that. Turns out a lot of men have IBS, but they seek care for it less often. About 12% of primary care visits and 25% of GI visits are for irritable bowel. These are patients who have a 2 to 4 times increased risk of suicidal behavior. They're in chronic pain, and they're at increased risk of killing themselves because of, maybe not because of that pain, but in association with that pain. When you look at active military and recently deployed, there's a much greater risk of irritable bowel syndrome and associated functional bowel disorders in military. So we've got a big population moving across the medical system now. The cost of IBS is huge. 36 million physician visits. When you look at direct and indirect costs, 20 billion a year. It decreased productivity. So in patients with IBS, the report is that 14 hours of the 40-hour work week, they feel impaired. So when that happens, you're going to have a less productive workforce. And if this is affecting 7% of your population with IBS, you add all the other chronic pain disorders on, you can imagine how many hours of American workforce productivity is decreased and diminished. Patients utilize 50% more resources than matched controls. So a patient with IBS is not just this expensive because they have IBS. It's because they also have other comorbid pain disorders. They also have comorbid psychiatric disorders, and they have 3 times as many surgeries as other people. So when we talk about IBS as a model, they're a model because they have, they really represent a complex population that includes somatic pain as well as psychiatric illness. Irritable bowel syndrome has standard criteria, which will be changing a bit this year, but for the most part include abdominal pain or discomfort that are at least 3 days a month. Most patients will have symptoms most days. And they're associated with at least 2 of the following symptoms: an improvement with defecation, an onset of the pain with a change in stool frequency, or an onset in a change with a change in stool consistency. So while people think about irritable bowel as a disorder of bowel movements, it's actually a pain condition which is associated with changes in bowel habits. Over the years, our evolution and understanding what IBS is has changed quite a bit. So back in the 50s, similar to inflammatory bowel disease, which is what we call a clearly organic disorder, both of those disorders were thought to be psychological. If you look back at Harrison's textbook of medicine, there's talk about the mother being, a cold mother leading to bowel problems, and it really was just thought to be completely psychological. In the 60s, people started to realize, you know what, this isn't necessarily the case, and they thought, well, these people have constipation, they have diarrhea, this must be from abnormal motor function. It turns out when they measured these things, motor function is difficult to measure, but as they became better and better at measuring motor function, it turned out that most patients with irritable bowel have absolutely normal motor function. And so it's only a very small number of patients that had this particular problem. And so research moved to the area of visceral hyperalgesia. So we think that the whole GI tract is more sensitive to normal activity and painful stimuli. And we measure that by putting balloons into the bowel and distending them and causing pain and having people say that hurts. And if they had IBS, you'd be more likely to have that happen. Initially, that was thought to be the answer. Most patients had visceral hypersensitivity. It turns out with careful work that's been done over the last 20 years, it's maybe half to 60% of patients with IBS have visceral hyperalgesia. Some have hypoalgesia, and many are normalgesic, so they respond just like healthy people, yet they still have these same symptoms. We realized more recently that the brain is involved, and the brain-gut interactions probably modulate irritable bowel. Thus, mind-body interventions may be helpful, and increasingly interactions between the microbes in the gut, the immune system, in the mucosa, and in the brain, and the entire nervous system are probably important in this disorder. So we've come full circle to really a systemic whole body disorder. Understanding the pathophysiology of IBS has made us realize that we have to attach the brain back onto the gut, and we can't just study these cells, the smooth muscle cells, the immune cells, the endochromaffin cells, the enteric nervous system. We have to look at those things in the context of the microbiome that lives within the gut and the brain and its function, which is connected to the gut and really modulates and often controls its function. So we know the brain is involved in IBS. During experimental pain, we know that IBS have more than healthy patients increased activity in emotional arousal in interoceptive regions of the brain, decreased activity in those frontal regions that we consider modulatory over the pain circuitry. They have altered resting state brain function and alterations in brain structure. And it turns out in areas that are similar often to patients with other types of chronic pain, like low back pain, migraines, and fibromyalgia. So when we encode chronic pain in the brain, we start with physiologic or pathophysiologic body signals, and I think it's important to realize that sometimes these signals are really physiologic, but the perception of them becomes shifted. Those signals go into the nervous system, the peripheral nervous system, up to the brain. We generate, at least in this theory, which is adapted from work by Bud Craig, we generate a conscious gut feeling from this signal that comes from the periphery, and it starts in the posterior insula. So much of our sensation from internal body parts goes to the posterior insula, the primary interoceptive cortex, and that is an area which we don't sense consciously. It's an unconscious part of the brain. It's processed over layers to this brighter conscious signal that some consider being emanating from the anterior insula, the area where we feel how we are at any given moment on a conscious level, after it's been processed through memory and reward circuitry and emotional circuitry and our huge prefrontal cortex, which modifies these signals to what we determine how this is how we feel, and this is what my pain is today. So we then have that feeling that's derived from the context in which we have this physiologic signal, and we encode a memory that stays with us, so that if we end up in that context again, we more rapidly may come to that memory feeling of pain. And then we then have a recall of that memory in response to internal and external cues. And as most people recognize from their own experience, internal and external cues have a very strong and rapid response in the gut. You get nervous about something, you feel it in your gut very quickly often. And so that can be from an internal or an external stimulus, no longer requiring the actual stimulus that starts within the gut. And so it creates this circle of perpetual symptoms. The three key functional networks have been identified as important in IBS visceral pain response. So sensation, the brainstem, the thalamus, the insula, the cingulate, cortical modulatory regions, which are decreased in IBS, in the frontal cortex, and emotional regions, particularly the pregenual anterior cingulate cortex, and in some studies the amygdala. The circuitry in IBS in response to a painful stimulus is different. So on the left, in a control group, you have in blue negative inhibitory. You have inhibitory stimuli that counter the emotional arousal circuit between the amygdala and the cingulate cortex. Whereas in IBS patients, when you model this, they actually lose that inhibitory stimulus. And interestingly, you can pharmacologically modulate this in a tryptophan depletion protocol so that you can make female controls in female IBS look similar with this modulation. So it is something that is changeable. What we've also identified over the last 10 years or so is that expectation of visceral pain is abnormal in IBS, and is probably the key thing that we have to work with. So it's not just that they have a painful stimulus when they eat or at various times in the day. They expect that and have pain from the expectation alone. So in this healthy control person, they have a balloon placed in the rectum that is not inflated, and they're told, we're going to inflate it right now. And the brain responds to that with the anterior insula, so activity in the anterior insula and deactivation in the pre-genial cingulate, an area where emotion, fear, etc., emotions related to pain occur. So the preparation for pain occurs. If you take a patient who has normal sensitivity to that rectal balloon, so they don't have visceral hypersensitivity, you put them in the exact same situation, what you have is activation of the bilateral insula. They're responding as if you've already inflated the balloon. And if you take someone who's hypersensitive, they not only activate the bilateral insula, they also activate the thalamus, as if they are having a painful stimuli occur when nothing has actually changed. So expectation of visceral pain in a patient with IBS, particularly as they're more hypersensitive, looks just like the delivery of pain. So the preparation for pain is faulty. So really we think that worrying about pain, this error prediction about what the sensory state will be, can drive pain. So you wake up, you say, I'm worried that my pain will be unbearable today. Something happens, you eat breakfast and your stomach starts to move, maybe physiologic. You feel something, and boom, that memory of pain comes in, and already the pain is there before anything really abnormal has occurred in the gut. So you can see when that's what we think is going on, when we treat with organ-based approaches to IBS, say with laxatives, with prescription medications that increase bowel movements, or in a diarrhea situation with antidiarrheals, antibiotics, bile acid binders to reduce the diarrhea, or pain medications, you can see how we may not be necessarily making a huge dent in symptoms. And this is why when we look at our prescription medications, so linaclotide being one of the more recent, constipation, rifaximin being the most recent approved in diarrhea, we see maybe a 30% response rate with 10% improvement over the placebo in these trials. We see a very small improvement for drugs that help bowel movement some, but don't help the overall distress that patients have, don't help their pain. So this is why we look to mind-body based approaches. So hypnosis, it just sounds so magical to me. It's always been my favorite. In hypnosis, it turns out is really helpful for pain, right? So hypnosis being a state of consciousness with decreased voluntary action responsive to suggestion or direction makes people nervous. Patients who undergo medical hypnosis are not unable to have willful action. They're not in a state where they are controlled by another person. They're in a state that is deeply relaxing, in which they're more ready to accept positive suggestion. So hypnosis has been studied in IBS for many years. It utilizes deep relaxation, imagery, positive suggestions for decreased pain, normalizing bowel function and reducing anxiety, as well as regaining a sense of control. And when I first read the scripts, the standardized scripts that have been developed for IBS, I was really surprised. They consist of a very long standard induction of hypnosis with deep relaxation that have nothing to do with the gut whatsoever, about 20 minutes of that, and then a small insertion of positive suggestions such as those that are listed here about positive and beneficial things happening in the gut. And when reading them, I would have thought, wow, I can't believe that this is helpful for IBS. But when you look at how people do, if you compare hypnotherapy to medical therapy, which would be in some studies antispasmodic, in other studies of bowel movement, targeted therapy, and other studies, and I'm just showing one here, they've looked at antidepressants, you see that hypnosis does much better in change of symptoms. In the bottom graph, There's very few studies that look at long-term follow-up of patients who've had reduced symptoms with an intervention for IBS. This looked at patients within the United Kingdom medical system over 5 years and shows that they actually maintain their benefit for a very long time. And this is for an intervention that is usually 10 visits. So this is not an ongoing hypnotic intervention. It's something they do, may have some refresher courses, but appear to derive long-term benefit. Most studies that look at hypnosis are looking at the effects biologically of acute hypnosis rather than the chronic effects that may occur when someone is using hypnosis regularly for a symptom. It's thought that the anterior cingulate cortex and its connectivity is the target of hypnosis, and improving the integration of cognitive modulatory processes with sensory and affective processing is thought to be the key to the beneficial response. And so these are the same areas in which we've talked about that are abnormal in IBS. So boosting the cognitive modulatory processes, dampening the pain and emotional arousal circuitry. In this study, which is a small randomized controlled trial of patients with IBS, looking at hypnotherapy versus education, we looked at IBS symptom severity, and we looked at the brain in response to provoked visceral pain, which has been a standard stimulus in pharmacological studies for IBS. We saw that patients had a decrease in their pain severity score in both groups. When we use this particular measure, a change of 50 points or more is considered clinically significant. So both groups had a clinically significant response. Hypnosis looks a bit better. When we looked at those people who responded to hypnotherapy, these same images that I showed you previously, before hypnotherapy, you see these are both normal and hypersensitive patients. You see this activity in the anterior insula when they're expecting pain and when the pain is delivered. And after hypnotherapy, you see a huge dampening of that insula response. And they look, if you remember, like the healthy control. A little bit of the frontal cortex, a little bit in the anterior insula. Preparation for what's going to happen, and then they sense it without this massive bilateral activation of the insula and the thalamus. So on a biological level, that's what's happening. And if you want to look at it in more detail, in the slides later, here are the pictures of the hypnosis responders, etc. A little hard to see on the screen, though. So hypnosis works, and there appears to be a biologic way that it's working. Cognitive behavioral therapy, and this is one of the books that I really like. Jeff Lackner, who's done a lot of the research in cognitive behavioral therapy for IBS, wrote a very detailed patient manual for this, which I like to give to my patients when they're particularly interested in this approach. So cognitive behavioral therapy is mind-body. It's pretty traditional, but it's a mind-body approach. And it's based on the premise that maladaptive learning plays a key role in the disease chronicity, that modification of these cognitive processes through therapy can reduce GI symptoms and symptom-related distress, but not just distress, symptoms too, and that cognitive techniques can include reducing negative biased thinking, catastrophizing, pain catastrophizing being high in IBS, as well as other pain disorders. Those cognitive techniques can reduce that negative biased thinking. Many of the behavioral techniques are based on relaxation and breath training to reduce the hyperresponsiveness of the nervous system. And in a meta-analysis of CBT for IBS, it showed that to reduce IBS symptoms 50%, which is significant, the number needed to treat is 2 to 4. So really a pretty good bet that your patients will get significant improvement with this, generally outperforming any of our pharmacological therapy and efficacy. Is this commonly used for IBS? No. CBT is very rarely used for IBS outside of Northwestern University, University of Buffalo, where Dr. Lackner works. A few sites where they really focus on this. We don't have anyone here at UCLA who does CBT for irritable bowel. And it really is specialized training. And so people say, well, it's not covered, I can't afford it. I know some people in the community I can refer people to, but nobody ever wants to pay for it. And when you think about a patient who comes to the doctor in Los Angeles, patient goes to the community, they have diarrhea, they have constipation, it doesn't matter how old they are, it doesn't matter what their labs look like, many of them will get a colonoscopy. That's quite expensive. And then they will say, oh, take fiber, and they won't get better, and then they'll go to another gastroenterologist. And then sometimes they'll go to like a third one, and I'm usually like the third or fourth that they see, and many patients have had at least one colonoscopy, many times an endoscopy they didn't need, and sometimes multiple procedures. And if you took the money from that, you could have a couple years worth of cognitive behavioral therapy if you really think about it. So our system has not really allowed an effective therapy like CBT to be readily available to patients. Now, to be fair, the patients have to do the work in CBT, whereas coming to the doctor,
or having colonoscopy, no work at all.
Well, people would rather come and have another colonoscopy. It's amazing than like really sit down with a therapist often, because they're really having trouble with this concept that why would CBT help my diarrhea?
Or why is it not covered? Because then you're dealing with comorbid anxiety and depression, and then CBT should be covered for that.
Yes, and often, patients don't necessarily want an additional diagnosis for anxiety or depression. There are some ramifications in terms of disability coverage, etc., for such diagnoses. But also, even if it's covered in a very limited group of therapists for many people on their insurance. Yeah. And so they call and they say, does anyone know IBS? And my experience referring patients out is that often I get people back that say, well, the therapist said just to come back to you for my bowels. They said, my relationship with my husband's fine. Like, well, you know what? That wasn't really what I referred you for. Not everyone that they're able to see has specialized training in pain. And of course, I don't always get to talk to the therapist and say, did you really say that? But it takes a therapist who is willing to work through medical symptoms and have the comfort in accepting my interpretation that this is not a life-threatening illness. So I work with therapists regularly in the community, and I have some that will, that'll call me and say, like, are you sure there isn't something else going on with this patient? I just want to make sure there isn't an organic disorder that we're missing as I do hypnotherapy. And I'll say, sure, I've taken a careful look, or maybe I need to take a careful look. So having physicians and psychologists work closely in tandem with patients with chronic pain is really the best model. It's not a model that most physicians and patients have access to. But in sites where they do, I think it's really effective. So CBT works really well. So percent responder rate. So you see in the silver and the green, this is in silver what's called minimal contact CBT. They have, I think, 3 visits and the rest is all online, so they're not even visiting the therapist that much. In green, standard CBT. So people do well with minimal contact, looking at adequate relief of their bowel symptoms, pain, and global improvement, compared to a waitlist control, which doesn't really help people much. The mechanisms are presumed to be similar to that of hypnosis. Prefrontal cortical inhibition of emotional arousal should be improved. You see decreased activity in the amygdala and the pregenial cingulate after CBT. These are small studies, though. In social anxiety, and I think more recently in depression as well, pre-treatment fMRI can actually predict treatment response better than clinical parameters, which may help us understand what's going on in some patients, even though it's not a practical thing to do in the clinic. We're not going to send people for an fMRI, but it may help us understand what we're actually treating in hone-in. We currently have a collaboration with Dr. Lackner in a big multi-site clinical trial for CBT, in which we're doing brain imaging to see can we identify treatment responders at baseline and to clarify the mechanisms of treatment response. And that's a large NIH-funded project through the NIDDK, which funds digestive research. So getting back to, can you have institutes that are focused on organic disorders funding mind-body research? You can. It's just not very easy, as people think. Meditation, how might it improve chronic pain? Well, there are a number of studies that show that it does. We think that, again, changes in the central and peripheral nervous system, immune changes, and changes in cognition and emotion. Turns out that meditation changes gray matter, so you actually can have increased gray matter density after mindfulness-based stress reduction, MBSR training. So that's in naive meditators that learn a new skill. If you look at long-term meditators, they have increased gray matter density in these areas as well. So it does appear to be something that is present with meditation and changeable. There are a number of effects on the white matter, so those tracks that connect different regions of our brain, sort of our superhighways of the brain. Mindfulness training, again, in naive meditators, can lead to improved integrity of the tracks within the brain. And those areas are associated with these things that we're very interested in, emotional and cognitive control. Meditation may have some effects on cerebral blood flow, improving cerebral blood flow in a number of regions of the brain, and may alter the autonomic nervous system, which is really the tract that goes to the gut as well and alters gut function. Slightly peripheral, but probably also associated with pain. There probably are inflammatory aspects of pain conditions, and particularly painful conditions in the bowel, in terms of immune activation, though not over inflammation. It turns out that people with who are undergoing meditation training can reduce their inflammatory parameters as well. And I just love this because, not just because it's Dr. Levetsky's work, the idea that with very simple meditation, this is something like we talked about earlier, picking a very discrete intervention, which is a chanting meditation for 12 minutes a day, very discrete, in a discrete population, and showing that you can have a biological change, so a change in telomerase activity in people who are doing this very specific intervention. And it's certainly, whenever I fall off the wagon of meditation, I go back to just this idea, 12 minutes a day, I can stay younger and more healthy. And I tell my patients it's kind of nice to have something to hang your hat on. You'll be younger if you do this. Meditation is a challenge for clinical studies. There's so many kinds of meditation, so many people who have their favorite that they want to do. What's happening inside the meditator when you do it? Are they really meditating? Are they just sitting there? Will we ever know? Does it matter? Is there a metric to measure meditation? There are a number of questionnaires, all of them fairly problematic. So it's very nice when we can go to a biological outcome that we can measure. Mindfulness-based stress reduction is one of the types of interventions that includes meditation that is most commonly studied because it is a very standardized. It's been around for a long time. It was developed in the 70s. It's based on ancient teachings, but it's really westernized. And it includes a non-judgmental focus of attention on the present moment with a release of past and future thoughts. What is it good for? In a recent meta-analysis with over 3,500 participants, they showed that MBSR training, or 8 weeks, could reduce anxiety, depression, and pain, all with small to moderate effect sizes. Did not have effects on some of the other conditions looked at. IBS was one that there wasn't enough data in their analysis to show a difference. But showed that meditation was no better than other active treatments. So other active treatments being, say, an opiate for pain or an antidepressant for depression or anxiety. However, one can imagine, and really when we design our research studies need to measure, the fact that when we stop the training for meditation, we've hopefully, if we've done something useful, made a change in the brain and in the habits of the person that can have long-term benefits and are pretty unlikely to have aversive side effects, though in some people it is possible. When we compare that to the standard active treatments, like an antidepressant for which there are many side effects, and for which when you stop them, they may not have any long-term residual benefit. And certainly opiates, we know, not a great treatment for chronic pain. And so not on comparison, if mindfulness is no better than opiates for chronic pain, I'll take the mindfulness any day of the week and leave the opiates behind, given all the potential dangers involved. Mm-hmm. So what about for IBS, the model we're talking about? Well, there was a study that was done and published in 2011 that studied mindfulness-based stress reduction for IBS against a support group control. 69% of the women with IBS showed a clinically significant improvement at 3 months, and their improvement was greater than in the support group control, which also improved. Quality of life, visceral anxiety, which is a specific index that we measure with questionnaire and IBS, and psychological distress were also improved at 3-month follow-up. So we've looked at, this one's not IBS, we've looked at mindfulness-based stress reduction at the VA as implemented for any comers, anyone interested in taking the class, so across diagnosis. Seems to help depression, seems to help anxiety, decrease the frequency of suicidal thoughts. In this group, there's no change in the pain scores overall, but if you took people who actually had significant pain, they seem to improve. We have been looking at MBSR for IBS at UCLA in a study that looks at the standard training with brain imaging before and afterwards. In our population of 61 patients, 71% had a clinically significant response that in the scale greater than 50 points. You can see at the pre-visit, their score was 268 mean with a standard deviation of 76. Afterwards, the mean score 177. So some of these patients decreased by 100 points or more, with 50 being what we're targeting for minimum. We used the 5-facet mindfulness questionnaire, which is one of the questionnaires that is been used for mindfulness. I think it's a difficult one, but it's interesting because it does break down mindfulness into different components. And what we were trying to figure out is there some aspect of mindfulness that's particularly relevant for IBS so that we can hone our mindfulness from a standard MBSR training for anything to one that really helps IBS. And the two components that are predictive of symptom improvement are if you improve the act-aware, so coming off of autopilot and acting with awareness in the present moment, and being able to describe what was going on. These two components of mindfulness, if they improved, IBS symptoms would improve. The other components were less predictive, and those components are being non-reactive, being non-judgmental, and being able to observe. So that's an area where people are starting to try to tease out what aspects of mindfulness might be really important for each clinical condition. We also saw improvements in quality of life, anxiety, visceral sensitivity index. And in a subsample that underwent arterial spin labeling, which is a way of non-invasively looking at cerebral blood flow with MRI, we saw increased blood flow in the hippocampus, the thalamus, the posterior insula, and the fusiform gyrus. So the thalamus and posterior insula we've talked about, these are your interoceptive regions, the hippocampus being an area that in other meditation studies has been shown to be beneficially affected by meditation. So we think that there's a biology to this, and this is something that not published yet. We're just getting started on our analysis. So hopefully we'll find more interesting things to come. The last thing I wanted to talk about is in irritable bowel syndrome, and you can look at this in pain too, though I think it's not as prominent. Is it all just placebo? Maybe it's just, we're doing all these fancy things, hypnosis, you need a psychologist, and you need consent, and all this. Could it just be placebo? So in this beautiful study by Ted Kapchuk and Tony Lumbo and others, They took 80 IBS patients, they randomized them to 3 weeks of placebo, no treatment, and they gave both, or no treatment, they gave both treatments in a warm, supportive patient-practitioner relationship. So this is one of the nicest gastroenterologists, Tony Lembo, that you could ever meet. He is very kind, and he was particularly kind to these patients. They were told they were being given placebo pills, something like sugar pills, that have been shown with rigorous clinical testing to produce significant mind-body self-healing processes. So they were told, this is open label placebo trial, giving you a placebo that's going to help you. It was biased in the instructions, but wait, where's my, okay. So when you look at no treatment in the white bar and open placebo in the gray, you look at global improvement, adequate, which is in the top left, adequate relief on the bottom left. You see that both of them had significant improvements in these scales. Symptom severity on the top right, using the very same scale that I've been talking about this entire time, the IBS symptom severity scale. People given an open placebo for 3 weeks, well, they had a greater than 50-point increase, improvement in their symptoms in that as well. And so it really raises this issue of specificity. If I can give someone a placebo in my, and just to see them in a warm, caring environment, and I make them better, well, why should I send them to 2 hours a week of mindfulness-based stress reduction? I'm not presenting this because I think that a placebo pill is actually better. This is a 3-week trial. It's small. It's very specific. We don't have any further biological outcomes. I'm fairly certain that if these people left after 3 weeks and then we checked them a year later, their symptoms would be back, or 3 months later. Their symptoms would return at a much higher rate than if they had done any of these other things. But it does raise the issue that it's very important for us to be careful about how we measure improvement in patients with chronic pain and irritable bowel syndrome. We can't just ask the question, did the IBS-SS get better? We have to also say, well, is there something biological that has improved, and a mechanism that has improved, and did the patient stay better for a significant period of time after we stopped our intervention? We're looking at 3-month follow-up, 6-month follow-up, 1-year follow-up. Are they still better after we've trained them? Did we make a significant change above and beyond the change that we can make as clinicians, being kind to patients and seeing them once a week for 3 weeks? And so I want to skip to my closing slides because acupuncture isn't really relevant to this particular. So how do mind-body treatments line up against peripherally targeted treatments? Oh, sorry. We're really, when we look at, say, linaclotide for constipation, or even Imodium for diarrhea, and mind-body therapy like mindfulness-based stress reduction, we're measuring apples and oranges. It is kind of hard to compare them. But if we look at a really loose way of trying to weigh them for responder rates, CBT on the left, a weightless control, rifaximin, an antibiotic that potentially has long-term effects on our gut microflora, and of course costs about $500. Placebo, Amitiza, or a different, which is another prescription medication for constipation. For placebo, the responder rate is better for mind-body therapies. People would argue that it's because we're making the patients happier, or that we don't have good placebo controls, or etc. The fact of the matter is, almost every mind-body intervention that we've studied shows a higher responder rate than any of the drugs that I can prescribe. And so it's really important to look at these, to try to understand the plausible mechanisms, to look at efficacy, to try to do realistic looks at cost, and not just cost of this pill versus this intervention, but the cost of healthcare utilization, the cost of potential side effects of drugs, and the potential for non-specific benefits like improved anxiety and depression of mind-body therapies targeted at IBS, to look at things like risk. One of the drugs that we use for IBS has a potentially fatal side effect. Is it worth that risk, or should I send them to CBT where I don't have that risk? Patient acceptance, what do patients want to do? How can we customize or use alternative interventions to make them more helpful? And so with all of that, I want to thank you for your attention. And I wish that most of the audience was able to ask me questions, because I'd be happy to answer them. But if anyone here in this audience has a question, I'd be happy to answer that as well.
I wonder that among the patient, which characteristic of the patient is suitable for the camp, or Yeah,
it's a great question, and one that's not been looked at very carefully. So certainly there's a bias when we do these studies. We recruit people who are willing to come and do these studies, though they are also compensated, so I think it's not severely biased. I would say, and I think it's the same as I would say for medical therapy, is if you have a patient who wants to, it has a priori belief that this will help them, those are the people who are going to do the best, right? Or a patient that even if at the baseline they may not want to do that, but you can explain it in such a way that they're willing to do it. I don't push people into therapies that they don't particularly want, because they're unlikely to benefit. When we look at subgroups, so in hypnosis, and I think also in cognitive behavioral therapy, the subgroup of patients with IBS that did the worst were men with diarrhea-predominant IBS. Nobody's looked into that further to say, well, could we have been missing some other disorder? Maybe those men with diarrhea-predominant IBS had a rare bile acid malabsorption syndromes or something else. I think also in the CBT study, they were not just men with diarrhea-predominant IBS, but they also had severe depression, so more severe depression. So there are some things that are not clear. But I think at this point, in IBS, the studies are small enough that we have not been able to do those kind of categorizations. So again, our group, we were looking at men and women, really hoping that we could make some sort of conclusion about, for mindfulness-based stress reduction, should I send my women at the same rate as I send my male patients? And unfortunately, it's so difficult to get male patients, and our group is much smaller. It turns out in our group, the men do much better. I mean, they all do well, but the men really do better. But it's a small group. It's 20 compared to 40. I don't know if that's just these guys who, are the really enthusiastic ones that we're going to get better anyway. So we really need bigger studies. The only other mindfulness MBSR study that I'm aware of that looked at sex differences, which is super important because really, particularly in disease groups, men and women behave much differently, was one looking at medical students and overall stress, and the women did much better than the men. So I was actually expecting better treatment responses in women. So I'm happy to be wrong, but I think we need more information. Most of the other studies have not found a big difference in terms of bowel habit, have not found big differences in anxiety going in, but higher levels of depression, they tend to respond less well.
Yeah, no, I wonder if personality characteristics could be responsible, like more neurotic or anxious men would have diarrhea type IBS,
Yeah.
And it's that predisposition, stress. Yeah. It's a stress deficit. What is responsible for that?
So, looking at catastrophizing and looking at, say, using the NEO to look at personality traits, so neuroticism is higher in IBS than it is in healthy controls. We know that. We haven't seen a correlation in treatment response with neuroticism, and we don't see a huge drop in pain catastrophizing, to be honest, with the intervention, which I would think, but it may be just that's so hardwired. But those are the types of questions that we need to look at to particularly when we're recommending an intervention that takes a lot of a patient's time and energy, to be able to say, the data supports this intervention for you specifically, not just I send all my patients to MBSR.
No, openness to an intervention is an important part, because if they don't care, they'll drag their feet through the study, but then forget it.
Yeah.
The important difference between pills and mind-body interventions is that you're giving them skills. It's a live coaching, live training of how to ward off stress or disease or pain.
Yeah, you're
Rather
putting
than-
the power back in the patient's core and giving them something that they can do so that when their symptoms do flare, because IBS is a cyclic process, it comes, it goes, it comes and goes, they don't necessarily have to pop back to the doctor each time. They have their skill set, their toolbox, and they're like, okay, my symptoms are flaring, I know what's going on, I have these tools to work with them, and they can often contain those symptoms and not have to go back to medications, or not have to come back to the
Because most of the Western medicine approach is symptomatic, it's temporary. Nothing provides a cure.
There's no cure.
And, you know, there are miracles with some mind-body approaches for those who pursue those.
Yeah, and we look at, with irritable bowel in particular, and with chronic pain, you know, when you look broadly, much of these are discrete episodes. So patient may have irritable bowel that's bothersome for a number of months or years, but if you go back 5 years later and you survey the same population, a third of those people no longer have IBS symptoms, and a new group has filled their place. So the level of IBS stays the same, but it's a constantly shifting population. The same with something like low back pain if you do that by surveys. The overall prevalence of it will stay the same, but people come in and out of the diagnosis. And we know that people who have one pain disorder at some point in their life are very likely to have another one at another point. So my hope is always, you know, I see them for IBS, but when their IBS is better, maybe their fibromyalgia will flare, or their migraines, or their low back pain, or something else. I'm giving them the tool that, yeah, I'm trying to make it specific to their IBS, but this is a skill set that is broad. When their back pain occurs, they can have this, you know, we use it for that as well. You can use it across the different disorders that you have, whereas targeting bowel habits alone is really just that discrete thing. So I think the difficulty of studying mind-body is that they're sort of general and broad and non-specific, but the benefit of using them as an intervention is that they're sort of broad and non-specific and may have beneficial effects across disciplines. Do you have a question?
I'm thinking about the placebo. It still works, right? I mean, it still works. So
At 3 weeks, yeah.
yeah. So I'm just interested if we give two groups, both of them are placebo, that we talk about. Oh, this one is more functional, more powerful.
Yeah.
Then.
Oh yeah. If we say we're going to give you a drug, and this one kind of gives you some side effects. We do what we do in the office. So I'm going to give you this pill. It may give you a little nausea. Some patients get headache, and maybe a little bit of your hair will fall out, but not much. But I think it'll help your IBS. And so you take that. And I have this other one. It has no side effects. It is awesome. It will get rid of your symptoms. I'm going to give that to you. Who's going to feel better? Well, that one that I gave, that I talked it up. This placebo trial, the placebo isn't just the pill. It's that statement that I'm going to give you a pill that's been rigorously studied and shown to improve your well-being. And really, all of us as clinicians should be maximizing that effect. It's a short-term effect, but every time we do any intervention, as much as we can within reason, we shouldn't make false claims, but we should really be maximizing the positive message that we can have as placebos all the time. But most placebo studies do show, if you look at people over a period of time, by 6 weeks out, that placebo effect often drops off. So this was a cute study and a nice study, and they have, if you're interested, they have a larger study, Dr. Kapchuk and Limbo and others, looking at acupuncture as a placebo intervention in irritable bowel syndrome using a supportive and non-supportive physician interaction, which is fascinating and very nicely done. There's a series of papers on that, which are really wonderful. And really showing that a big component is really how the acupuncturist interacted with the patient. It's not just the needles alone in irritable bowel syndrome. So probably the context in which we care for our patients is equally important to what we do with our intervention. And it's really those two things together that make the best patient care. We need an intervention that's more than placebo, but we have to present it in a way that's therapeutic.
Thank you.
You're welcome.
That was an enjoyable talk. I'm learning so much. Because I don't have a spare book yet, but there's an announcement. Just published book.
Oh, great.
Complimentary.
Wonderful. I'll have to get it for the library.
Yes, please do.
Well, I did feel a little funny talking to, like no one, and like, I don't know, maybe I should have
I do it all the time. You should.
Yeah, I don't usually practice my talks like from beginning to end with no one there. It's like I wasted time, but this is, useful.
It was adequate. I'll figure out what's going on, where this guy seems like a decent person. I've met him just now.
Yeah,
the new coordinator.
Yeah, it's a
but last time it was like nobody. Who do I talk to?
It was just you.
Yeah.
All right.
No, actually, we ended up with 8. Were you here last time when Kakit was?
Yes, I was here, but actually
I had like 7 people.
Last time when Dr. Hui just have a lecture here, and I just arrived 2 days before that. So
I see.
Actually,
you were
just
seriously, yeah.
all the time.
All
because
right.
of jet lag.
Thank you for
Thanks so
inviting
much.
me. I hope so. Thank you.
Yes, I made them.
You make them.
Yeah. Okay, so let's see.
Oh, Helen, I guess it would be something that we could link on our website too.
Absolutely.
So, do you know how
I'll
do
send
that?
it to you.
Send the link? Okay, perfect.
Yeah, and you just put it on your website.
Yeah, I'll just have our
Multiple
website
websites
person
with you.
just put it up so that,
Yeah. And the whole course, actually, I'm thinking. Yeah.
Yeah, it would be totally relevant for our center.
Yeah.
Yeah, all the
totally,
talks.
totally. We'll make it happen.
Okay.
Don't worry about it. Yeah. Thank you.
Thanks.
Thank you. Oh, yes. They're virtual listeners and, invisible friends. And,
It's very hot up there.
yeah, I thought it was
Right up
me.
at the door.
Do you have your own computer or I have mine?
I need to have it back.
You have it or not?
I have it on my computer.
Oh, you do? Okay.
Yeah, this is an audience of one.
No, we'll see if anybody's chimed in.
Are people
Video
on
call.
the video?
It's being recorded and we're putting it on our websites and everybody's website. Yeah. How are you?
How many people signed up for this?
We had 7 or 9 last time.
Wow.
But the problem is that CTSI coordinator evaporated, left right before New Year. And so I didn't realize that. I started emailing after New Year about webinars and seminars. And they say, oh, she's left, and the new person starts the day after. So I just met him today. And he doesn't know much about how to send out reminders. So I had to tell him what to do. And so he seems like he's left to his own devices too, because he knows of 10 to 15 people.
This is really ridiculous.
Yeah.
A lot of time to come up and do this.
Right. Sorry about that. Okay, so do you have a transition?
No, I don't. Do you have a zip drive?
I think I might. Let's see.
That's not what I want. I need to have a.
Let me
Do you
see.
have
I
a
don't have it. I might
USB
have it.
or? There's no.
I think that's the
There's no support for you.
No, he was here earlier. I have it. And Kirsten didn't want. She sent away the alternate. Let's see.
to just talk. Like it's a
No.
real audience. What happened to half my audience before I showed up?
I talk to myself all the time.
Yeah, but I'm not sure.
Okay, let me see. Let me call him in a second. I asked him to send the.
Hello, I'm Mike Irwin.
Nice to meet you.
Nice to meet you.
She's,
What's your name?
She's okay.
My first is Patari.
Mm-hmm.
Uh-huh.
She
My
just-
last is Pahon Park.
Okay.
But you can call me Marco.
And you're a fellow, or what's your status?
She's a fellow, yes. She's a visiting scholar from Thailand
I see.
for 3 years.
Right, wonderful. Who are you visiting?
Me.
Oh, okay.
Can you send an IT person? Are you okay? Controls, presentation. Do you know how to I think it's something function 5. Is, no?
I'll just shut down and start up again. So
Are you trying to manipulate it?
I'm going to shut down and see if it winds up. When I shut down.
Oh, hi, Dad. This is Helen Labretsky. You know, we had a switch of computers and we're not sure how to operate the system. Is it possible? Yeah. Okay. Okay, sounds good. Great, thanks. Just coming.
I'm going to try to boot it up from the start.
So we have fascinating data now with the Lazadon study. Did you hear?
No.
Okay. Good me. I know you haven't talked to me. But it's
Did you want to tell me about the data, or you just want to say it's fascinating?
Yes. So it's Steve Cole who did the analysis of microarrays, and he found a really strong signal for the Lazadon versus paroxetine. He says it's very unusual in NF-kappa B and AP1 pathways. So,
Nice.
yeah. So we're gonna write a paper about that, and hopefully, probably apply for a grant.
Let's see, let's go through this.
No?
Hi, Doug.
Hello.
Hi.
Okay.
I'm
So,
Irwin.
Done.
So I've got the thing on.
It's just this is what connects to the system from the. Is it over on
the
here?
HDMI?
Yes, it is.
Oh, okay.
And then
And this doesn't work?
presentation.
There it is. I saw something. Great.
Yeah, okay.
There
And
we
let me
go.
make sure that you're on video call. Still. Yes, and recording. Still good. So that should be.
And the microphone is, how is it recording with?
It's through the.
Oh, I see.
Okay, so.
It's through these
Okay.
in the table.
Oh, I see. Okay.
All right.
Is that
Great.
working?
Yeah,
Thank
that
you.
looks great. Thank you very much,
Fantastic.
Doug. I knew it would take 2 seconds.
No, it's
Sorry.
fine.
10 minutes to get here, right?
Thank you.
You can leave, yeah, you can leave it open. It's so bothering me.
Okay, we can probably start.
All right.
Talk to people.
Are they there?
Are they there?
Okay.
They're there. You're not seeing your voices heard, so you'll be here at the table. It's not important. It's just slides and your voiceover.
Okay, my name is Michael Irwin. I'm the director of the Cousins Center for Psychoneurology and also director of the Mindful Awareness Research Center, professor of psychiatry at UCLA. What I'm going to be talking about today is optimizing well-being and mindful awareness practices and the implications for depression, insomnia, and inflammation. And specifically, I'm going to be talking about optimizing sleep health with mindful awareness practices. The objectives of this talk are several-fold. One, to evaluate the importance of sleep health, a critical dimension of well-being, to evaluate the role of sleep on inflammation and biological aging, and to review the role of inflammation on mental and physical health. This really sets a groundwork, a framework for understanding how mind-body practices or mindful awareness practices can affect sleep with potential effects upon health outcomes. And we're going to examine the efficacy of various mindful awareness practices to impact sleep, as well as biological mechanisms that are implicated in health. And then finally, I'm going to specifically address how mindful awareness practices are very important in reducing inflammation, which is a key pathway for chronic disease risk in older adults as well as other populations. Sleep health is really a new concept that we need to be considering in the primary care setting, for example, and evaluating, just as we learned today, the very important role of screening for depression, publication of a JAMA article. It's also very important to screen for sleep problems. And typically when you go to a primary care physician, they rarely ask about sleep problems. And it's really critical that we train primary care physicians and other care providers to ask about the problems with sleep. Sleep can be defined by a variety of different components. We know that sleep duration is very important, and the optimal amount of sleep duration is between 6.5 and 7.5 hours of sleep per night. But probably more important in terms of health risk is the reports of sleep quality disturbances and the lack of restorative sleep. It's known that this kind of self-reported insomnia or deficits in sleep quality are associated with increases in mortality risk. Most of the large-scale epidemiologic studies, however, have not evaluated sleep quality, but simply ask how many hours of a night is a person sleeping. And when we can use that metric to evaluate insufficient sleep, we find that there's a number of states in the United States that have a sizable percentage of individuals that have limited amounts of sleep. Why is that important? A number of epidemiologic studies, probably nearly half a dozen, have shown that sleep duration is associated with mortality risk. And in all these data, what's really clear is that there's an optimal amount of sleep duration that's important. If you're either sleeping too long or too short, there's an increased rate or incidence of mortality. So typically a person that's sleeping less than 300 minutes, which is roughly 5 hours a night, is an increased risk of mortality. But a person that's sleeping much greater than 6 to 7 hours a night is also showing increased risk of mortality. So So there's an optimal amount between 6.5 to 7.5 hours of sleep that's being recommended. When you look at sleep duration in chronic diseases, and this is a large-scale epidemiologic study that was prospective in design that really puts into play or puts into test the notion that sleep duration actually has a role in prospectively leading to cancer and other diseases. We find that when the reference amount of sleep of 7 to 8 hours is used, those sleeping less than 6 hours had increased risk of stroke, increased risk of cancer, and also overall increased risk of chronic disease. Unfortunately, this study did not look at the long sleepers, those who are sleeping greater than 8 hours. And there's been a lot of controversy as to whether long sleeping is actually associated with disease risk and mortality, or whether it's a surrogate marker for underlying chronic disease that is not being evaluated in these large-scale epidemiologic studies. Nevertheless, when those variables are actually controlled, long sleep is also a significant predictor of chronic disease. So when you look at across multiple different diseases, you can see that sleep disturbance is really sitting right in the center, leading to mortality, associated with cancer risk, associated with diabetes risk and cardiovascular disease, as well as rheumatoid arthritis. In our group, we've been primarily interested in how sleep disturbance leads to depression. And depression is also a very important risk factor for each of these outcomes in and of itself. Critical to really designing interventions that can alleviate that can improve this risk profile is to evaluate the mechanisms that are associated with sleep and health outcomes. And two biological mechanisms are increasingly believed to be critical for being surrogate markers or biomarkers of subsequent disease risk. One is inflammation, and the other is biological aging. And a number of studies have now shown that sleep is associated with each of these outcomes. The model that we are really testing is to what extent sleep disturbance leads to inflammation and biological aging and ultimately morbidity and mortality risk. Why is it important to think about inflammation? Inflammation is really not only associated with chronic disease risk, but it really is at the intersection of behavioral, symptoms, and health. We know that increases of inflammation that are driven by sleep problems or chronic stress or even by depression lead to an activation of the sympathetic nervous system and changes in the hypothalamic pituitary adrenal axis, which in turn lead to increases in the genomic expression of inflammatory genes through the activation of nuclear factor kappa B and the secretion of pro-inflammatory cytokines such as TNF, IL-1, and IL-6. These particular cytokines not only regulate the immune system, but they also feed back and alter what's happening in the central nervous system and increase the likelihood that we're going to perceive experiences as stressful because they produce changes in our emotional sensitivity. They also produce increases in perceptions of pain or hyperalgesia. They can lead to fatigue, and they also contribute to depression itself. So these pro-inflammatory cytokines are not only regulating chronic disease risk, but are also regulating behavioral symptoms that can also contribute to chronic disease risk. Sleep disturbance really plays a critical role, and sleep can be evaluated in the laboratory by polysomnography or the electroencephalogram. And when you do that, you will find that there are 5 stages of sleep. More recently, stages 3 and 4 have been grouped together as slow wave sleep. Stage 1 is considered a very light amount of sleep when people are still somewhat conscious and aware of their environment, but their EEG is beginning to slow. Stage 2, you begin to see sleep spindles and changes in the sleep architecture, indicating that a person's entering a deeper stage of sleep. They're no longer now aware of sleep. Typically, that time into stage 2 sleep is the time of sleep onset, And a delay in that sleep onset is considered sleep onset latency, which is a measure of delayed sleep onset or latency. Stages 3 and 4 is deep sleep, and this is a time of very restful sleep. It's considered that deep sleep is really critical for one's health. We know that during deep sleep or slow wave sleep, there's an increase of growth hormone. There's also a marked decrease in the sympathetic arousal mechanisms and a decrease in sympathetic tone. As we then transition out of that slow wave sleep into REM sleep, there's an activation of sympathetic tone. And the EEG turns into what an EEG that looks very much like an awake EEG, except there's evidence of rapid eye movements, and there's also a loss of muscle tone. And there's a transition across the night throughout these cycles of sleep that lead to ultimately a redistribution of sleep depth. Most of the deep sleep is occurring in the early part of the night. Most of the REM sleep is occurring in the later part of the night. When you're having disturbances of sleep, what people are typically aware of is waking up throughout the night and then not being able to go back to sleep. And so they may have difficulty with sleep onset and have prolonged sleep onset latency. They may have increases in a number of wakings after sleep onset, or wake after arousal, we call that WASO, or they may have a decrease in sleep efficiency. These kinds of disturbances of sleep are often what people are aware of when they report non-restorative or poor sleep quality. Then the overall duration of sleep is mapped from the time of sleep onset to the time when the person wakes up. These disturbances of sleep and sleep continuity, as well as disturbances of sleep architecture, particularly the loss of slow wave sleep or an increase of REM sleep, produce changes in the efferent pathways that regulate the immune system, much like depression or much like stress does. So a person that's experiencing sleep disturbance is that they're having a prolonged episode of stress, for example, a marked increase in sympathetic activation throughout the night, or a failure to show a downregulation of the sympathetic arousal mechanisms throughout the night. It's known when that occurs in a person that has, for example, sleep apnea and repeated arousals, that kind of disturbance of sleep leads to increases in sympathetic tone and increases in heart rate as well as blood pressure and ultimately hypertensive disease risk and cardiovascular disease. We also know that the disturbances of sleep are very important in the regulation or lead to alterations in the immune system. The immune system is dynamically regulated throughout the night. There are both circadian factors as well as sleep-specific factors that play a role in the regulation of the immune system. And increases in REM sleep and increases in that sympathetic activity actually will lead to increases in pro-inflammatory cytokine expression. So you'll have an activation of NF-kappa B and ultimately transcription of genes that express pro-inflammatory cytokines and their release into the circulation. You can not only find that during the night when people are sleeping in association with that increases of REM sleep, but you can also find that during the day after there's a marked increases of REM sleep. Certain populations that have high levels of REM sleep, such as substance abuse populations, some depressed populations, will show this inflammation in association with this increases in REM sleep. In turn, these pro-inflammatory cytokines feed back and alter sleep. And the increases in pro-inflammatory cytokines we now know have a role in the regulation of sleep. Basic animal models have shown that pro-inflammatory cytokines can alter sleep continuity, they can alter sleep depth, and also REM sleep. In humans, the data are correlational, showing that increases of pro-inflammatory cytokines before we go to sleep lead to increases in sleep onset latency, or that is a delay in sleep. They also are associated with increases in REM sleep. So there's a reciprocal and what we might consider a vicious cycle between REM sleep and pro-inflammatory cytokines. The increases in pro-inflammatory cytokines increase REM sleep, which in turn promotes further increases in pro-inflammatory cytokines, which really argues that blocking either the inflammatory pathways, the sympathetic nervous system, or abrogating or changing the REM sleep abnormalities is really key. And I'll get into that in a little bit. So if you look at a population level and then really say, well, that's a nice base, many of that, what I've talked about is generated from animal models. What we now need to really evaluate is, do those relationships hold in humans? We've recently published a meta-analysis involving over 50,000 adults throughout the world in over 72 cohort studies that evaluated the association between self-reported sleep disturbance, evaluated by single items, evaluated by validated questionnaires, or by diagnostic interviews. And what these summary of these data show is that there's overall an association between sleep disturbance and increases of CRP, which is a marker of systemic inflammation, and also increases in interleukin-6. Now, the changes are not particularly robust, as you can see by the effect sizes, but they are statistically reliable, showing that sleep disturbance contributes to inflammation. The association between sleep disturbance and inflammation is similar to that between obesity and inflammation, between low physical activity and inflammation. So even though the effect sizes are not large, they're similar to other known risk factors that can drive increases in inflammation. The other thing I want to draw your attention to is that if you increase or improve the quality of the assessment of sleep disturbance, moving from single items to validated questionnaires to diagnostic interviews, the association actually improves or increases in magnitude. And we found that both for the CRP and IL-6. What's striking, however, not shown in this slide, is that when you evaluate sleep disturbance as measured by sleep duration, that is either long sleep duration or short sleep duration, you find that there's an association between long sleep duration and inflammation. But the association between short sleep duration and inflammation is not particularly robust and only found for CRP. So it really raises this question about, is it sleep disturbance or is it actually amount of sleep that's important, or some combination of the two? And unfortunately, very few studies have looked together at both sleep disturbance and sleep duration to evaluate that risk. However, in hypertensive disease, we know that the individuals that have short sleep duration and also report sleep disturbance have greater increases in hypertensive risk. And recent data from our group has also shown, when you look at biomarkers of disease risk and evaluate individuals that have sleep disturbance in either long or short sleep duration, that the effects of long sleep duration on these biomarkers of risk are only found in those individuals that have sleep disturbance. So there may be people that are sleeping long amounts of time that actually have good quality of sleep. So it's very critical in all these days to look at sleep disturbance. What's lacking in the literature are large-scale prospective studies that have tested that. There's only one prospective study in the literature that's looked at sleep disturbance and increases in inflammation, which is really quite shocking. So in our efforts then to understand the causal links between sleep and inflammation, we've taken an experimental approach. And a study now shown here that's nearly 10 years old, evaluated the role of sleep deprivation, looking at the upstream cellular and molecular processes that are involved in the regulation of systemic inflammation. We looked at a cellular marker of inflammation called toll-like receptor 4 stimulated production of pro-inflammatory cytokines. We know that the levels of systemic inflammation are not simply due to increases in activation of monocytes or cells of the immune system. The systemic inflammation, in fact, about 60% of circulating levels of interleukin-6, for example, are coming from adipose tissue. Another 20% are coming from skeletal muscle. So only a small fraction of IL-6s, for example, coming from the cellular immune sources. So we were very interested in knowing whether the association between sleep and inflammation is actually due to changes in immune system activity. Innate immune system activity can be evaluated by looking at the ability for a monocyte, which is a primary source of pro-inflammatory cytokines, to produce pro-inflammatory cytokines such as interleukin-6 and TNF following stimulation with lipopolysaccharide, which is a bacteria, the cell wall of the bacteria that can bind to the toll-like 4 receptor, producing this non-specific activation. On the right of this flow cytometric analysis is an individual that has having a normal night of sleep. And you can see that most of those monocytes are in the lower left quadrant, which indicates that they're not producing very much pro-inflammatory cytokines. But in this particular individual, even though that person's healthy, there's still some expression of pro-inflammatory cytokines. If you looked at older adults, or you looked at individuals that had cancer, or you looked at individuals that had rheumatoid arthritis, the unstimulated levels of pro-inflammatory cytokines would actually be higher than found in this control individual. What's striking, however, is when you look at the panel on the right, there's a marked increase in the cellular production of pro-inflammatory cytokines, both for TNF as well as IL-6. And this is for a single individual. And when you look at aggregate sample, you'll find that some individuals should show increases in pro-inflammatory cytokines with a preferential shift towards TNF, and others with a preferential shift towards interleukin-6. But on some, there's an increase in pro-inflammatory cytokine production. And what we now know is that this is not occurring similarly across both men and women. Women have a marked increase of this pro-inflammatory cytokine expression following sleep deprivation. And that would make sense in some ways for understanding how sleep may play a role for the increased risk for autoimmune disturbances found in women as compared to men, as well as the increased risk of depression in women as compared to men. We also conducted in this early study, I would consider a discovery approach to evaluate how powerful might be the signal between sleep and inflammation. And one of the ways of evaluating that relationship is to use a whole genome-wide or gene expression approach to look at 21,000 genes and evaluate in a discovery way what genes are differentially regulated. So we examined this large number of genes and found that 21 genes were differentially regulated. Of those, the majority, nearly 70%, had to do with the immune system. And half of those had to do with increases in inflammation, which I think is a really striking finding, that inflammation is really being clearly regulated by acute sleep deprivation. These data then pointed to the role of activation of NF-kappa B, which is a transcription factor that regulates inflammation. And subsequent studies showed that sleep deprivation produces an activation of NF-kappa B. And once again, women are more likely to show that activation following sleep deprivation than men. Inflammation is closely tied to molecular markers of aging. And when we increasingly begin to look at what we call the secretory senescent phenotype, or secretory associated senescent phenotype, which is essentially a characterization of an immune cell that is no longer able to function as a normal immune cell. When that cell reaches that stage of senescence, it's not able to divide, and there's also increases in inflammation. So inflammation can drive an immune cell towards that senescent phenotype. But that phenotype then produces further increases in inflammation. So there's a positive or vicious cycle feedback loop that can accelerate as we age. Sleep disturbance may have a very important role, not only in leading to increases of inflammation, but also increases in markers of cellular aging. And one of the broad markers of cellular aging is telomere length. And, this is actually, so this is actually, first before I get to telomere length, we looked at the gene expression profiles for the secretory associated senescent phenotype, and also the DNA damage response genes. There's a number of genes that are characterized as DNA damage response genes. And what we found is that a loss of sleep, even for this short period of time, we're talking about 4 hours a night, produces an increase in these markers of, that are associated with immune senescence and also DNA damage. These in turn then can alter an enzyme that is protective for the telomere, that is telomerase. And preliminary data has also shown that there's some changes in telomerase activity following sleep deprivation. So we've recently gone on to evaluate the association between insomnia and a marker of cellular aging, and that is telomere length. And this was just reported this last month in Sleep, a journal for sleep research. And in this particular study, we asked 2 questions. One is there an association between insomnia and telomere length? And does insomnia actually lead to decreases or shortening of the telomere? And secondly, is there some interaction between age and insomnia to increase that? We know that as we age, the DNA repair mechanisms and telomerase activity wanes. And so it may be that individuals that have insomnia that are younger age actually have high enough levels of function of telomerase to be able to repair their telomeres. Whereas individuals that are older do not have that kind of active repair mechanisms in place. And what we found was that insomnia is associated with significant decrease of telomere length in individuals that are older than 70 years of age, but not in individuals between 60 and 69. So inflammation is not only very important in mental and physical health, but is also increasingly viewed as important in mortality risk. And specifically, I just want to draw your attention to a recent work coming out of looking at CRP as predicting of mortality risk in cancer survivors. So I don't want to leave you with the impression that sleep leads to inflammation, that all inflammation is actually bad. Because inflammation is really playing a very critical role in the regulation of the immune system. And in times of sleep disturbance, or at times of threat, or times when we have injury, we need to have a very active inflammatory response. And so the inflammatory response actually serves a very important role in priming the rest of the immune system to respond to infectious challenges so that it can be cleared effectively. However, in times of chronic stress or chronic sleep disturbance or depression, or when those stresses become perpetuated over time, that inflammation becomes can produce untoward effects upon our body. And we consider this a conserved transcriptional response to adversity. That is, there are 2 changes that are occurring. One, there's an increase of inflammation at times of social stress and potential sleep disturbance. There's also a decrease in antiviral immune responses during these times. I don't have the time to go into the role of sleep disturbance and antiviral immune responses, but a number of studies have now shown, both using experimental as well as naturalistic observational designs, that sleep disturbance is associated with decreases in antiviral immune responses, increases in infectious disease risks, such as the common cold, and decreases in responses to vaccines. So you're getting really 2 effects of sleep disturbance, much like you find with aging or chronic stress. An increase of inflammation and a decrease of antiviral immune responses. Why is this so important? Because this inflammatory response, we think, increases the sensitivity or sensitizes us to subsequent challenges. If you have an increase in inflammation that may be driven by a single night of sleep disturbance, that may not have much consequence on itself. But that repeated disturbance leads to increases in the priming of that immune system. And so subsequent challenges to the immune system may lead to an exaggerated increase in pro-inflammatory cytokine responses. We also know, and I'm going to talk about in just a moment, how inflammation can increase risk for depression. This chronic inflammation that occurs with repeated disturbances of sleep may be a pathway by which we see changes in neuroinflammatory sensitization, so that an individual that's exposed now to a simple stressor, such as an interpersonal conflict, or has a subsequent infection that leads to marked increases in inflammation, that second hit leads to then changes in the CNS regulation, which ultimately leads to depression, particularly in vulnerable individuals that may have chronic sleep disturbance or individuals that have ongoing or past history of a major depressive disorder. Now, within this context, I really want to frame the notion that sleep disturbance is operating in consideration of the genetic factors, the personality factors, and socio-environmental conditions of the person. In all these associations between chronic stress and depression, we know less about sleep disturbance. A person's genetic factors are also very critical. There are cytokine gene polymorphisms, and certain cytokine gene polymorphisms, for example, an interleukin-6 promoter polymorphism, is associated with increases in pro-inflammatory cytokine responses. And so, for example, we know that increases in inflammation in depression occur, and that leads to mortality risk. But that association between depression and mortality risk is only found in an individual that is heterozygote for the interleukin-6 promoter that leads to the increases of interleukin-6. The association is no longer present when that heterozygote is present, or when the heterozygote, the GG heterozygote or homozygote is present. So we need to take into account these genetic factors in evaluating sleep disturbance and ultimately elevations in inflammation, ongoing risk. And also, there's certain factors of a personality, such as sensitivity to emotional responses, that's also very critical. And then chronic environmental conditions, particularly socioeconomic issues, living under an environment of chronic socioeconomic distress or social inequality can also lead to increases in inflammation and also contribute to sleep disturbance. So over time, this can increase elevated inflammation, which then leads to anxiety and depression, and ultimately chronic disease risk. So much of the data that I'm really been talking about is suggesting that sleep disturbance leads to inflammation, leads to depression, is all based upon cross-sectional data or naturalistic observational data. So we've once again taken an experimental strategy to provoke inflammatory response and use this model to also evaluate to what degree sleep disturbance is actually driving or associated with that risk. That endotoxin, or the LPS, that can bind to the toll-like receptor produce the increases in inflammation, can be also administered intravenously or systemically to a person in a safe way. And it provides an experimental model to produce a marked increase of inflammation that can then be evaluated as a way to test how inflammation is causally associated with changes in physiologic states and increases in changes in depressed mood. When you do that to healthy individuals and give a very low dose, they have almost no sickness symptoms. A high dose, we know, produces even septicemia and produces death. But a lower dose produces only mild elevations in blood pressure, maybe some nausea, shaking chills. And if you move that dose even lower to 0.8 nanograms per kilogram range, which is the dose being used here, you see only very trivial changes in these sickness symptoms of nausea, fever, shaking chills, and they typically occur after a person's experienced depression. So in the first panel on the right, you'll see that there's a marked increase of inflammation found with the administration of the endotoxin. And so there's a subsequent increase in depressed mood that follows, and also increase in feelings of social disconnection. These increases in inflammation are associated with depressed mood and primarily found in females and not in males. We've now conducted a much larger scale study showing that males and females show almost identical activation of the pro-inflammatory cytokines in response to this endotoxin challenge. but only the women appear to be sensitive to the induction of depressive symptoms. And so we're very, we're now, and the correlations between increases in inflammation and depression are only found in the women, not in the males. We're very intrigued by that, and we'd like to know what it is that's actually protective. This association between inflammation and depressed mood is due to an activation of brain sites that are implicated in the pathophysiology of depression, and particularly activation of the dorsal anterior cingulate cortex, which is shown in the upper panel, or the anterior insula, which is shown on the lower panel. In both instances, increases in inflammation are associated with these increases in these sites, and the depressed mood is associated with increases in these sites. And importantly, when you do a mediational analysis and evaluate whether the association between inflammation to depressed mood, inflammation to activation of these sites to depressed mood, you find that these sites are mediating the increases in depressed mood. Another really key component of inflammation and depression is anhedonia. And anhedonia is a loss of pleasure. We also find that inflammation increases anhedonia or induces anhedonia, decreases the ability to anticipate reward, which is a component of anhedonia. So if you can't look forward to doing something, you wouldn't often be motivated to actually take action to do that particular task. That's really prominent in depressed patients. When we look at the brains of these individuals that are exposed to endotoxin, we actually find a decrease in ventral striatal activity, which is a site in the brain that's very much involved in reward processing. Now, sleep is increasingly viewed as important as a risk factor for depression. I've talked about that. It's associated with inflammation. And when we stratify this sample of individuals that are experiencing or have administered the endotoxin challenge and have this marked increase of inflammation, we find that the association between endotoxin producing increases of depressed mood is only found, or most primarily found, in the subgroup that has poor sleep quality. The individuals that come into the study with good sleep do not have that significant increase in depressed mood. Now that you can see that even when they come into the study, there's a modest increase in depressed mood among the poor sleeping group, but that's not statistically different. So even when you control for levels of baseline depressive symptoms, you find that that sleep disturbance moderates the association or the effects of inflammation in inducing depression in this experimental model. What's further striking is that that's only found in women. So men with poor sleep quality just do not show this increase in depression. Women do. So women have this marked increase of inflammation. And then this increased risk of depression in association with that inflammation, and also are susceptible to this two hits, that is having the sleep disturbance and having the inflammatory challenge, puts them at marked increased risk. So in designing studies that could actually prevent depression, it may be that women maybe an important vulnerable population, particularly women who have either ongoing inflammation or have ongoing persistent sleep problems. So what can we do about this? And this is a talk that's really focused on mind-body issues, or this lecture series, and so now I want to move to the role of mindful awareness practices to promote sleep. There are really two primary treatments that have been used to improve sleep in the adult literature as well as the older adult literature, and they are cognitive behavioral therapy for insomnia and pharmacotherapy, particularly benzodiazepines for the treatment of insomnia. Pharmacotherapy is very effective in the management of short-term insomnia, but it's only effective as long as a person's taking the medication. That when a person stops taking that medication, the insomnia symptoms typically relapse. And importantly, particularly in older adults, pharmacotherapy can increase the likelihood or the number of adverse effects, including poor concentration during the day, fatigue during the day, increases in depressed mood, but particularly worrisome for older adults who take a sleep aid at night is they wake up to go to the bathroom, for example, and fall because they are having the effects of that medication on board, which can produce hip fracture or other complications. Treatment trials that have actually evaluated the efficacy of CBT versus pharmacotherapy have really found almost identical effects. However, cognitive therapy does not have the adverse effects of pharmacotherapy. It also has long-term benefits, and after the cognitive therapy has been learned by the person, it has long-term effects for up to a year, and longitudinal studies have evaluated this. Now, in this particular trial, what I think is also striking is that it also shows that cognitive therapy may have some greater benefit in the treatment of sleep problems than even pharmacotherapy. And you can look at the sleep efficiency, and that is the improvements in sleep efficiency. Sleep efficiency is essentially the amount of time that a person's asleep out of the amount of time that they're in bed. And you can see in the CBT group, both in mid-treatment and after treatment, there are really robust increases in sleep efficiency, and only really modest increases in sleep efficiency in the pharmacotherapy group, and really nothing to be gained by giving the combination therapy. And each of these is really superior to the placebo group. Now, knowing this, then why wouldn't you just say, let's go ahead and give cognitive behavioral therapy to individuals? Cognitive behavioral therapy has been known to be effective for nearly 15, almost 20 years, with numerous trials showing it's very effective. However, it takes a skilled practitioner in order for it to be delivered. It's expensive. In most primary care settings, including collaborative care settings, it's not widely used. So cognitive behavioral therapy, even though it's effective, is very hard to implement in community-based settings due to the expense and the need for a highly trained therapist. So we do need therapies that are accessible, that are cost-effective, and also can be used in a self-care manner to improve sleep. Importantly, most cognitive behavioral therapy is really only prescribed, so to speak, for people with insomnia. But if you look at most of the general population, they have moderate sleep complaints and which don't yet meet the threshold for having insomnia. So we evaluated to what extent we could actually improve sleep quality among this group that have moderate sleep complaints and also have some daytime impairment, but use an intervention that could be taught to the person in the community, and then they could take it into their home and practice. And this was a mindful meditation experience. So they learned how to sit quietly, become aware of their surroundings. And it's a mindfulness approach that is implemented over 6 weeks. And so there's mindful eating, mindful walking, relational mindfulness, being able to talk to another in a mindful way. And we compared that to a health education intervention, an intervention that's been widely used in a public health setting to improve sleep. But it has, we know, really modest efficacy and really no long-term efficacy in the treatment of sleep problems. What we found this is a randomized controlled trial of older adults, and at the pre-intervention period, we found the two groups were identical in their baseline characteristics, demographically as well as in the severity of sleep disturbance. But after the treatment with the MAPS, the Mindful Awareness Practices treatment, there's a significant improvement in the Pittsburgh Sleep Quality Index, which is a measure of sleep quality. The magnitude or the effect size of improvement with the MAPS is equivalent to the effect sizes found with CBT. This study, however, begs the question as to whether these effects are comparable to the standard of behavioral treatment, which is CBT. Also, this is a short-term study. We don't know whether these effects are maintained over the long term. What we found when we asked the patients how they were implementing this approach, we asked them to use the mindfulness awareness practice or the mindfulness approach between 10 and 30 minutes before they go to sleep each night. We also found that they practiced in that way, but they also, when they woke up throughout the night, they used that MAPS approach to help them return to sleep again. So it's improving both, I think, the sleep onset latency as well as the sleep efficiency, which is why we get these improvements in sleep quality. In addition to the improvements in sleep quality, we also found improvements in fatigue, and we also found improvements in depressive symptoms.
What is control group?
The control group is a sleep health education group. So teaching them simply components of sleep hygiene that are delivered to them in a standard way. We also talk about other health style practices that may contribute to improved sleep. So getting exercise, eating healthy, the sleep tips are the routine sleep tips of making sure that your sleep is following a regular schedule, that your bedroom is quiet and dark, that you don't do anything else in your bed except try to sleep or have sex, that you essentially maintain a regular sleep schedule, that you don't use caffeine, and that you refrain from excessive alcohol use. So these are very routine educational information that can improve sleep in a modest way, as you can see, but the MAPS was superior to that. Further studies have really evaluated another mindful awareness practice, which we call Tai Chi. This is a movement meditation that we found could improve, much as we found with the MAPS study, improve people that have moderate sleep complaints in the short term. So we recently conducted a large-scale longitudinal follow-up study of 123 older adults with insomnia, not just moderate sleep complaints, but actually had clinical insomnia. And we evaluated the ability for cognitive behavioral therapy versus Tai Chi versus a health education control group to improve these sleep outcomes. And what we found was that both Tai Chi and the CBT could improve the sleep quality as compared to the health education as found in the post-intervention and also at the 7-month follow-up. But by the 16-month follow-up, the Tai Chi participants had returned to levels comparable to the control group of the sleep seminar. So that's disappointing. So we get these short-term improvements in sleep quality found with the Tai Chi group, but they are not maintained over the long term. And part of the reason that they're not maintained is that people simply stop practicing the Tai Chi. So we need to use these mind-body interventions and provide mechanisms or booster sessions that can foster the continued practice of the mind-body intervention, because only when they practice them do they work. In contrast, the CBT approach, they learn how to manage their sleep, address their dysfunctional beliefs about sleep, and we see that the long-term benefits of sleep are present. In addition to improvements in sleep, we also found improvements in fatigue severity and also improvements in depressive symptoms. And in this particular instance, depressive symptoms were really significantly improved, really comparable to the improvements found with the CBT in both the Tai Chi and CBT groups. But once again, the effects were not maintained in the long term in the Tai Chi group, only in the short term interval. Now, in addition, we've been very interested in what happens to biomarkers of disease risk. So one of the questions that we've been asking is that sleep disturbance can lead to changes in health. But there's really an absence of randomized control data that has evaluated to what degree sleep disturbance is causally linked to these health outcomes. We can evaluate biomarkers of disease risk by attaining multiple markers of disease. Hemoglobin A1C, for example, is associated with diabetes. Levels of circulating lipids, changes in circulating catecholamines, increases in inflammation. These surrogate or these markers are then combined into an overall score. And we use clinical cut points to define individuals that are having high risk or normal risk. And what we can show is that the individuals that have good sleep quality at 4 months show a decrease in their overall scores on these indices as compared to individuals that have poor sleep quality. And that difference is maintained at the 16-month follow-up. And importantly, when we look at the relationship between Tai Chi, CBT, and sleep seminar, the effects of CBT are once again maintained in the long term, and we also find that the effects of Tai Chi are maintained in the long term, even though we didn't find this maintenance of the sleep improvements. So that really raises the question: is that Tai Chi is maybe not just impacting sleep health, it's impacting other indices of health through other mechanisms than sleep problems per se. And this really raises the question, can we use other mindful awareness practices to reverse inflammation? And we recently conducted a meta-analysis examining that question, where we've evaluated the efficacy of a number of mind-body therapies, Tai Chi, yoga, meditation, mindful awareness practices, and find, once again, modest but statistically significant effect sizes for these mind-body therapies on circulating levels of inflammation. Coming back to this notion that if we target sleep disturbance using a mind-body therapy in an at-risk sample of people with late-life insomnia, can we actually alter markers of inflammation that are associated with disease risk? And CRP, particularly high-risk CRP, that is greater than 3 picograms per ml, is associated with increases in cardiovascular disease as well as depression. So we ask in the insomnia treatment trial to what degree the administration of either CBT or Tai Chi could alter the proportion of individuals that have high C-reactive protein. As you can see, when people come into the study, they have similar proportion of high-risk CRP. At the 4-month interval, where we find really equivalent improvements in sleep quality in the Tai Chi and the CBT group, there's also somewhat of a slight decrease in the proportion of individuals that have high-risk CRP. The sleep seminar individuals show a further increase in individuals that have high-risk CRP. We're not surprised by that increase that's occurring over time. A number of studies have found that even 3 months, 4 months, 1 year, a chronic disease, and now we think sleep disturbance, is that chronic stress or depression or sleep disturbance is associated with a progressive increase of inflammation, and what we find in this short-term follow-up, a progressive increase of high-risk CRP. The individuals that are then followed at 16 months, we find that the increase of CRP proportion is maintained in the sleep seminar group. And once again, this Tai Chi group, who do not practice their Tai Chi, have an increase in that CRP. But what's striking is that the treatment of the sleep disturbance with CBT produces a marked decrease in the proportion of individuals that have high-risk CRP. And when you look at the effect sizes of the ability to treat sleep disturbance with decreases of CRP, these are really twofold greater effect sizes than found with physical activity. That is, if you prescribe to an individual physical exercise, that is, going and working out on a regular basis, the effect sizes to achieve that benefit are greater by simply with the treatment of sleep. Likewise, you see a similar benefit or greater benefit treatment of sleep than with dietary manipulations. And we know that it is in fact the sleep disturbance is critical, because when you stratify the sample on non-remitters or emitters of sleep disturbance, the differences are found at 16 months between those two groups.
And the remitters in what?
emitters of insomnia. This is an insomnia treatment study.
Oh, and so what did you say about dietary? What is better than dietary?
So
sleep improvement.
So
when
you look at the effect sizes found with the treatment of sleep disturbance with CBT, or the effect sizes between the non-remitters and the remitters of the 16-month follow-up, that effect size is greater than found with physical activity or found with dietary manipulations that are known to reduce inflammation. These are the longitudinal studies, so instead of just looking at high proportion of CRP, you can also see similar results when you evaluate individuals or the mean levels of CRP over time.
And how the effect sizes, how are they compared to depression ones?
Depression treatment is only modestly associated with improvements in CRP. There's only a handful of studies that looked at that level. So, if we know that systemic inflammation is being improved, a critical question is asking also, what about the cellular and genomic mechanisms that we know contribute to inflammation? And one particular mechanism that we know is the cellular production of pro-inflammatory cytokines using this stimulated toll-like receptor 4 activation of monocytes. And what we find is that Tai Chi, which is a lower dotted line, produces a very robust and sustained decrease in the cellular activation of monocytes. So those monocytes simply are not producing the amount of inflammatory cytokines, the TNF and interleukin 6, as found before the treatment of sleep problems. And what's once again striking about this is it's not just due to improvements of sleep. So it indicates that the Tai Chi is having maybe effects indirectly through sleep on the cellular production of pro-inflammatory cytokines, but is having potentially other mechanisms coming into play. And one mechanism that's not reported here that we're currently evaluating is the role of heart rate variability or the sympathetic vagal tone. And what we found is that increases in vagal tone, which have been shown to decrease pro-inflammatory cytokine activation at the monocytic level, that increases in vagal tone occur in the individuals who are practicing Tai Chi, and it correlates temporally with the decreases in cellular production of pro-inflammatory cytokines. We also find that the treatment of sleep problems in the CBT group produces a decrease of pro-inflammatory cytokine expression. But that's only in the short term. It is at the mid-intervention point. Even though sleep is improving in that group, the sleep treatment is not improving the cellular expression of pro-inflammatory cytokines in the CBT group. However, when you look at the genomic pathways and look at constellation of pro-inflammatory cytokine genes that are being differentially regulated in the CBT group versus the sleep seminar group or the Tai Chi group with the sleep seminar group, you find a very similar pattern of regulation. A downregulation of NF-kappa B transcription pathways in both the CBT as well as in the Tai Chi group, and a downregulation of AP1 pathways. It's interesting also in the CBT group, you find an increase of interferon response pathways, which are the pathways that are implicated in antiviral immune defenses. And this makes sense that the treatment of sleep may actually improve or decrease the susceptibility to infectious disease risk, knowing that insomnia is associated with increases in infectious disease risk. The ability for Tai Chi to improve or alter cellular markers of inflammation are not just found in older adults. We've replicated this finding in breast cancer survivors with insomnia, finding that as compared to CBT, that the Tai Chi produces a decrease in the cellular expression of pro-inflammatory cytokines, and also a decrease in the the pro-inflammatory cytokine genes in the Tai Chi group as compared to the CBT group, and an increase in the antiviral immune response genes in the Tai Chi group. We didn't find that in the older adults that practiced Tai Chi, but we did find that in the individuals that that were breast cancer survivors. This finding that a mindful awareness practice, Tai Chi, could produce downregulation of pro-inflammatory cytokine gene expression has now been replicated in several studies. One of the first studies that we did was using a mindful-based stress reduction approach in older adults and finding a nearly identical pattern of responses. Dr. Lavretsky, in collaboration with our group, David Black and Steve Cole, have found that a yogic meditation also decreases NF-kappa B transcriptional pathways and increases in interferon response pathways in individuals that are caregivers for a person with dementia. And then Dr. Bauer, looking at the same pathways using another mind-body intervention, yoga, also decreases inflammatory signaling in fatigued breast cancers, finding, once again, a downregulation of NF-kappa B pathways and showing that that is primarily due to downregulation of activation in the monocytes as a particular cell type. So, in thinking about this, I don't think we should say it's either Tai Chi or yoga or meditation or mindfulness. Each of these practices is going to produce some benefit. And what I think is really important as we move this into the public health setting and community is really talk with our providers about teaching people a variety of different approaches to improve, or they could use as a toolbox, so to speak, for to decrease their inflammation, improve their overall health outcomes. So maybe then one day Tai Chi could work for a person because that really fits with their schedule or whatever, and another day of mindfulness practice, another day of yoga. But being able to have each of these approaches and being able to use them is important. Also, we need to tailor these approaches to that particular person. Some people really like Tai Chi, some people like mindfulness. So being able to fit the practice to the individual is also critical. So before I end, this is really a model that's framed in a psychoneuroimmunology framework, conceptually linking the interactions between the brain to the physical and social environment, how we interact with our physical and social environment, and how we perceive our day-to-day experience, whether things are stressful, leads to changes in the regulation of pathways from the brain, which in turn impact the immune system. The immune system is then stimulated or not to produce these pro-inflammatory cytokines to respond to infectious agents. But the immune system is also sensing signals within the body of challenges. So if we have an infectious agent, or we have a wound, or some other injury, that signal is being sensed by the immune cell and then transmitted to the brain to alter the behavior. So there's a reciprocal interaction between the neural and innate immune systems to not only regulate the immune system, but also regulate the central nervous system. And in so doing, alter how we're interacting with our physical and social environment. So in conclusion, sleep disturbance really is very important to evaluate. It impacts a course of inflammatory disorders. We've shown that targeting sleep disturbance may actually prevent or forestall the onset of diseases if the findings showing that targeting or decreasing inflammation can be translated into these clinical health outcomes. Mind-body interventions, meditation, Tai Chi, yoga appear to have robust effects upon cellular inflammation, inflammatory gene expression. Their ability to impact more broad measures of inflammation, such as CRP and circulating levels of interleukin-6, are not as evident, possibly because a number of other factors can lead to changes in these markers of cellular or systemic inflammation. Nevertheless, I think one of the things that we do know, and I would recommend, is that mind-body interventions be used as a treatment strategy to alleviate stress, and particularly to target insomnia. They can be delivered in the community. They can be delivered at the person level. So once a person learns these approaches, they can be delivered in their own home and used to promote their own well-being. They appear to not only target these behaviors, such as sleep disturbance and potentially depression, but they target the whole body. And in the instance of Tai Chi, we're seeing that it may improve sleep, but it's also producing changes in the stress response diathesis with improvements in the immune system that are independent of the improvements of sleep. And so finally, I want to really end with the notion that these mind-body interventions are very well accepted. They're accepted in not only older adults and adult population, but in patient populations. And I really contrast this with a number of large-scale trials that have attempted to prescribe exercise, aerobic exercise, to patient populations. And we find that adherence to exercise is very limited, despite the knowledge that it improves outcomes. That remains a challenge with mind-body interventions, is how to maintain the benefits that we see over time in these individuals. Thank you very much.
It's amazing. Your slide with difficult review, I think has this public health significance, you know, but also public appeal.
Yes.
You know, that's how you publicize how empower an individual to control their world inside and out.
Yes.
Right?
Yes.
So I think that's the main message.
The main message is that
you are in control.
I think that having people learn that they can adapt strategies to respond to the daily onslaught of stressors, whether they be trivial or significant, that we face. And we're all going to face adversities throughout our life. And we're going to face day-to-day adversities. Even challenges of coming to work can be
but also management of chronic disease.
But how then to regulate our responses? That regulation of responses may improve that inflammatory cascade, which then alters that ultimately disease risk, chronic disease. So implementing these strategies in young adults is really critical, I think, because it can alter the trajectory of outcome of these individuals.
Yeah.
But also targeting people that are very vulnerable, that we know are vulnerable, such as breast cancer survivors, that have really profound disturbances of sleep, that have changes in the inflammatory pathways, and where we know already that depression, sleep, and inflammation can contribute to cancer recurrence. Targeting those individuals and altering this system of regulation may alter that recurrence of cancer disease.
Kirsten, also, you know, just listening to your results with CBT, I don't understand why the government would not cover CBT for everybody with chronic disease. The effects are so profound, it seems like, for sleep.
Yeah, I agree with you, Helen, that the effects have been profoundly demonstrated for the treatment of sleep for at least 15 years. There was a recent review, a meta-analysis was done by us over 10 years ago, another meta-analysis, over 15 years ago. So there's been a wide amount of data. But despite that, if you go to your primary care provider, and they don't ask, first of all, rarely they ask about sleep problems, but if they do ask about sleep disturbance, they don't have access to a cognitive behavioral therapist that can deliver the treatment. So their response to that sleep disturbance is to give you a medication and send you home. And we know through a number of studies that principle doesn't particularly adverse to risk. So we do need to educate the primary care providers, and I think really demand that collaborative care models integrate cognitive behavioral therapists with expertise for depression and sleep treatment into these settings.
Yeah, Kirsten also was saying the same thing, same situation with pain, CBT being effective for pain and chronic disease management not being available anywhere.
But I do want to emphasize that even if the government came forward and was able to fully support the treatment of insomnia with CBT, the resources are limited. CBT is a clinical condition, and only a fraction of people that have sleep complaints meet clinical criteria for having insomnia. So people with moderate sleep complaints, which is the vast majority of older adults that have, have moderate sleep complaints, those moderate sleep complaints also are contributing to inflammation, also contributing to potential disease risk. And being able to target those moderate sleep complaints using interventions that can be implemented in the community, that don't require government approval because they don't meet the threshold of a clinical diagnosis, I think are also necessary. So that's a really important role for mind-body interventions. In addition, I think mind-body interventions have the potential to forestall the onset of clinical insomnia. So if you treat a person, so sleep disturbance is healthy sleep is a learned behavior. If you're having sleep problems, those sleep problems that you're experiencing are learned over time, and they become perpetuated, more severe. And so being able to target those moderate sleep complaints before they become learned and conditioned and ingrained may actually forestall the onset of the clinical insomnia with huge savings, not only to the healthcare system, but to the person and also to the risk for chronic medical burden.
Okay, very good. Thank you so much.
Yep, you're very welcome.
Excellent. So thank you for coming, and sorry for the limited audience, but we'll expand.
Well, I hope that
we'll expand.
whatever it's the rest of the